presentation. Hello, everyone, and welcome to today's webinar, Applying Evidence for Best Practice in Mental Health Settings. My name is Amanda, and I'm the Marketing Manager here at AOTA, and I'm going to point out a few things about today's presentation. First, CE. You can earn 1 CE contact hour for attending today's Member Appreciation Plus webinar. At the conclusion of the webinar, you will receive an email from AOTA Webcast containing a link to your CE certificate. However, you must stay on for the entire webinar until you view the pop-up screen that says the webinar is now over in order to receive your CE certificate email. You will have through February 8th, 2021 to obtain your CE certificate. Next, questions. On the left side of your screen, you'll see an Ask a Question box. This is for you to type in questions you may have for our presenters throughout the webinar. Questions will be answered toward the end of the webinar, and our presenter will do her best to answer as many questions as time allows. And last, resources. The PowerPoint presentation, along with other resources for this webinar, are available for download and can be found in the Event Resources box located just below the Ask a Question box. Simply click on the pull-down arrow to view the documents and download. And with all of that helpful information, let me introduce today's presenter, Elizabeth Lannigan.
Hello, thank you. I'd like to introduce myself. I'm currently serving as adjunct faculty in the occupational therapy program at the University of New Hampshire. My mental health practice experience has included acute care, long-term inpatient, and community mental health settings. I have primarily served individuals living with serious mental illness with a focus on employment intervention. Together with Dr. Susan Noyes, I co-authored the Occupational Therapy Practice Guidelines for Adults Living with Serious Mental Illness. I presented at AOTA conferences and offered an AOTA CE online course in hopes of promoting the clinical applications of evidence described within these practice guidelines. Throughout my involvement with AOTA, I have served in many leadership capacities. I'm currently the Mental Health SIS Chair, and I'm a member of the Commission on Practice. As Amanda said, I provided the script for this presentation, so my hope is that you sit and relax and listen. Please download the course resources, and later you can retrieve detailed information with this webinar. Today's webinar focuses on program planning in mental health settings. I'm focusing on the settings as opposed to individual cases. To address client needs within specific clinical settings, OT practitioners need to understand the challenges experienced by the setting's client group in order to identify and implement appropriate evidence-based interventions. I will introduce the process of completing setting-specific needs assessments with strategies to identify the specific client challenges addressed in designing OT intervention programs. The subsequent step of reviewing evidence-based interventions will be detailed as part of the clinical reasoning to identify relevant effective interventions. The AOTA Evidence-Based Practice Project solicited topics from practice experts regarding intervention effectiveness. AOTA determined the 5 focused systematic review questions to serve as the basis for analyzing current intervention research studies. It was expected that these systematic review findings would generate knowledge of intervention effectiveness that promote best practice occupational therapy services for clients. The practice guidelines begin with an overview of the OT process for adults living with serious mental illness. Next, the practice guidelines present 5 systematic review chapters which detail evidence for OT intervention effectiveness. There are additional resources that provide further descriptions of implementing evidence-based interventions for individual clients. The practice guidelines provide 3 case descriptions which demonstrate examples of evidence-based effective intervention. Another individual case is presented in the AJA Evidence Connection article. And the Practice Guidelines Continuing Education online course with an additional case is available for purchase from the AOTA store. In healthcare, practice guidelines serve two clear purposes. First, to ensure that we as occupational therapy practitioners deliver best practice to the clients we serve. But equally important, the guidelines are used as educational resources. As OT professionals, we must educate our team members and administrators, as well as reimbursers and policy setters, about the distinct value of OT mental health services. Evidence validating OT intervention services is critical to gaining respect for the unique yet complementary OT mental health services. Utilizing evidence for best practice is one of three types of information for clinical decision making. First, as practitioners, we seek critical information from clients and their families and/or immediate support systems, such as the client's unique preferences and values, in addition to their cultural and population-based characteristics. Second, we utilize the expertise that we have developed as practitioners, such as our knowledge base and our practitioner unique skill sets. Then the third leg of this triangle is the incorporation of evidence-based practice. This is the process of decision-making, or matching best available evidence to practice situations. This professional reasoning utilizes a science-based process for solving practice needs found in our clinical settings. To expand, the science-based process, defined as knowledge translation, helps us identify and implement effective interventions appropriately in clinical settings. For practitioners, we need to engage in continual critical reflecting about our interventions through professional reasoning. Knowing that interventions have generally worked in the past is important, but not sufficient. To consider specific client needs in our practice settings, the task is to seek out evidence that supports effective interventions for client needs. To consider suitable evidence for selecting effective interventions, OT practitioners begin with the process of program development. We start by understanding what challenges are experienced by the clients within our specific setting through the lens of the OT process. First, we identify the occupational performance and participation needs of the setting's client group. This enables us as practitioners to identify what clinical dilemmas require the distinct value of OT services. Second, we need to determine what are the professional questions that we need to ask regarding these dilemmas, which are interfering or limiting clients from greater occupational engagement. Once these questions are identified, we can focus on the search for effective interventions. This step in program planning, in the program planning process, is the time at which practitioners seek intervention evidence relative to client needs within the specific setting. This serves as the foundation for intervention planning and implementation. The systematic review findings and the practice guidelines provide OT practitioners with resources for the knowledge translation process. These summaries of effective intervention evidence are already compiled evidence descriptions. These enable practitioners to match client needs to relevant services, thus engaging in evidence-based practice. This knowledge translation process leads to achieving best client outcomes based on the delivery of effective and quality interventions for the specific clinical setting. Assertive community treatment is one type of agency providing services for individuals living with serious mental illness. Its strength is in providing individualized services for persons who experience a high level of need for services to support their successful community living. As an evidence-based approach, ACT's mission is to meet all client needs across the timeline of 24 hours, 7 days, 365 days a year. Duration of services is not time limited. The term assertive refers to the intensity of services provided to support clients. Through case management, all team members act as primary service providers in natural community environments for treatment, rehabilitation, and support. With a person-centered approach, ACT addresses clients' values, goals, strengths, and challenges in a strength-based model. ACT uses a transdisciplinary model in which each discipline assesses clients' needs from that discipline's lens that contribute to the client's treatment plan. Then the assigned team member serves as the case manager, providing all needed services from the various team professional backgrounds. On the ACT team, the OT practitioner may provide case manager duties, being responsible for all needs for the assigned caseload. ACT incorporates the recovery model, which is described as supporting a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. This recovery model is defined by SAMHSA. The ACT's program mission and structures include staffing structures for availability to clients round the clock, and the sharing of discipline-specific duties. This results in staff having small caseloads and providing intense level of services, dependent on this team approach with professional role blurring for service delivery. OT roles within the ACT transdisciplinary model include establishing the contribution of OT's distinct value as expertise and occupational performance, engaging in case manager duties, and being comfortable with a transdisciplinary role blurring approach. For requested add-on OT services, providing specific OT direct care interventions. And for requested consultation to the ACT team, providing staff education for topics such as how to develop skills for community living and/or how to provide environmental modifications and supports. Through this ACT team case example, I will outline the process of program development to establish evidence-based practice. In this example, the OT practitioner was asked to provide OT add-on direct services and thus needed to design a program of intervention services to support clients' community living. To do so, the practitioner utilized a needs assessment to identify challenges experienced by the client and to understand the agency's organization. For clients, the needs assessment questions included client characteristics, capacities, gaps in performance, and desires. This generated a description of the clients. The clients ranged in age from 30 to 55 years, and most lived with serious mental illness for 5 to 25 years. Their housing situations range from independent living in own homes to supportive apartments or living with families. Some clients had either full or part-time employment. Others were unemployed. Most clients had limited social networks and limited engagement in recreation activities. Most clients experienced intact capacities in basic daily living skills. They were also self-directed in goal setting and expressed desires for meaningful occupation. Yet the clients demonstrated limitations in aspects including higher level cognition, such as executive functioning, in social interaction skills, and in performance patterns of habits, routines, roles for ADLs and IADLs, and finally in occupational engagement. Clients expressed that they were seeking participation in employment or volunteer roles, in social participation, and in leisure occupation. As related concerns, it was apparent that clients were impacted by issues of stigma as well as issues of health and wellness. This is important because the OTPF4 has added the new occupation of health management. For the ACT setting, the needs assessment questions included: what are the setting's mission and program structures? How do OT approaches fit into the ACT model? How does the OT scope of practice match the ACT model? What are the supports and barriers to OT services? And what are the needed stakeholder negotiations concerning OT services? This generated a description of the agency. As I said before, the ACT agency had a transdisciplinary team approach. The OT approaches of occupation-based interventions, skill-building interventions for community living, and environmental supports, which are based on occupation-based models or frames of reference, are all compatible with the ACT model. OT scope of practice to support client occupational engagement and participation in community living matched the ACT model. It is important to identify what supports and barriers to OT services exist within the agency's approach. A support is the team approach to serving clients, but a barrier may be the intense level of services with availability to clients 24/7 and the need to provide direct assistance at times rather than intervention to enable clients to do for themselves. To establish interprofessional collaboration and have a willingness to share and accept expertise with team members is needed to establish the stakeholder collaboration. In completing the needs assessment, the OT practitioner formed a foundation for developing OT intervention programs. The needs assessment identified specific challenges in community living experienced by the setting's clients. Priorities for OT interventions based on gaps in performance and occupation areas included: for ADLs and IADLs, clients varied in assistance needed to perform basic self-care, community mobility and transportation, financial management, meal preparation, shopping, and other tasks. In the area of work, for either paid employment or volunteering, most clients needed assistance to reach desired work occupations. And in the occupations of social participation and leisure, most clients needed assistance to participate or expand their social and leisure engagement. The OT practitioner also recognized the importance of focusing on underlying factors to support client participation in these occupations. intervention was needed to incorporate assistance for performance patterns of habits, routines, and roles, and for performance skills, especially for social interaction skills. There was also needed consideration of client factors, such as cognition, to support performance skills, especially for process skills. Having synthesized the client challenges data, the OT practitioner also needed to integrate the OT program development into the mission and structure of the ACT model. In the subsequent step of reviewing evidence-based interventions, the OT practitioner needed to reflect on how to integrate effective interventions into the ACT model to achieve the goal of enabling greater client community living skills. After completing the needs assessment, the OT practitioner needed to decide what questions to ask to start searching current evidence regarding effective intervention. The OT practitioner's professional reasoning is critical to determining suitable intervention. Let's consider this resource developed for the practice guidelines from the AOTA evidence-based project, especially this section which asks, what questions guide your thinking? What evidence exists? This resource offers guidance for implementing evidence-based practice based on questions to take into consideration when clinical gaps have been identified. The first question, how do we as OT practitioners know what are best practice interventions? We need to examine existing evidence for interventions addressing the occupations identified in the needs assessment. What evidence addresses the precise occupational needs experienced by the client? Additionally, where can evidence for these interventions be found? The practice guidelines provide analyses of intervention research studies. This information identifies interventions having strong or moderate level evidence for effectiveness. And the second major question, how do we as occupational therapy practitioners apply this information to our specific client? Meaning, how do we differentiate between interventions with strong evidence, and interventions lacking strong or moderate evidence? Understanding this evidence impacts practitioner selection of interventions to implement. It is also critical to ask the question, what is the impact of utilizing interventions which lack evidence for effectiveness? And the third category of questions, how do we link the selection of effective interventions to the desired outcomes for our specific client? How do we have confidence that our interventions will achieve the practice outcomes being sought for the client? It is not sufficient to implement evidence-based interventions demonstrating effectiveness. Practitioners should select evidence-based interventions which produce these desired outcomes for the specific population. And finally, once determining which effective interventions to select, we need to implement methods of these interventions consistently as outlined in the research evidence. Having described the challenges experienced by the ACT clients in this example and the process of examining existing evidence for effective interventions, I will now present evidence-based interventions outlined in the practice guidelines for adults with serious mental illness. A panel of experts were asked to identify what questions should be explored concerning occupation-focused interventions. This group determined the 5 systematic review questions to direct the analysis of the intervention research evidence. Each question was formulated to ask, what is the evidence for effectiveness of interventions for adults living with serious mental illness? This slide lists the 5 categories of interventions explored. A team of reviewers was assigned to each question, and they analyzed research studies to answer the specific question. These teams initially produced critically appraised topic papers for each theme identified within the question. These can be found on the AOTA website in the mental health practice category under evidence-based practice. Next, the teams authored AJET articles found in the September-October 2018 issue. Then Dr. Susan Noyes and I co-authored the Occupational Therapy Practice Guidelines for Adults Living with Serious Mental Illness, which summarized these 5 systematic reviews and reported findings on all intervention studies examined. The practice guidelines extended this information into applications for practice. The U.S. Preventative Services Task Force identified national standards for evidence as determined from research investigations across healthcare. Level of strength is the standard for evaluating research outcomes. This describes research methodology rigor, or the level of the research design, and the significance of findings, or the certainty that interventions will result in outcomes found in the research investigation. This slide explains levels of strength assigned to findings from research studies contained within the practice guidelines. This data enables OT practitioners to select strong or moderate evidence-based interventions from all interventions researched. It is recommended to avoid utilizing interventions with mixed, limited, or insufficient evidence. For the first systematic review question addressing ADLs, IADLs, social participation, leisure, and rest and sleep, 3 interventions demonstrated strong evidence. Occupation-based interventions, which engage clients in actual occupations to expand their capacities, demonstrated improved social participation and occupational engagement, and improved sleep, coping, and lifestyle changes. Psychoeducation interventions, which are manualized programs, demonstrated improved ADLs and IADLs, improved social participation and living skills, and improved medication and illness management. Social training interventions, which demonstrated improved social skills and participation, and also community living skills. The second question, addressing employment. 2 intervention categories demonstrated strong evidence. The first category is supportive employment with the individual placement and support model, known as IPS. In this model, clients are first placed in competitive employment, and then job training is provided. These interventions provide ongoing support as long as needed by the client. Support may be provided as job coaching on-site or as off-site assistance. The second category of interventions are those of cognitive interventions, specifically cognitive remediation training, which includes computer-assisted cognitive remediation sessions. Some interventions provide cognitive remediation interventions solely, and some combine these with vocational programming. Strong evidence for improved employment was demonstrated from both interventions. This included improved outcomes in both cognitive function and employment outcomes. The other occupation within the systematic review addressed an OT emerging area of practice. Supported education demonstrated moderate or limited evidence, but only 2 studies demonstrated the criteria to be included in the systematic review. The OT profession developed supported education interventions more than 10 years ago. Yet, there are only very limited number of studies. It is critical that we conduct studies and generate evidence for this intervention. The systematic review question addressing physical health and wellness focused on interventions for lifestyle behaviors, which aim to reduce physical health discrepancies as compared to health outcomes of the general population. All 4 interventions demonstrated strong evidence. The first being physical health interventions. These promote the absence or reduction in chronic medical diseases and promote the implementation of healthy lifestyles. These demonstrated increased visits to primary care providers and better medication adherence. They increased attitudes towards self-management and reduced substance dependence and hospitalization. The second intervention category, relaxation interventions, demonstrated the greatest evidence for yoga and progressive muscle relaxation, which reduced overall psychopathology and improved health-related quality of life. Exercise interventions resulted in the greatest evidence for cardiovascular exercise and walking to reduce anxiety, depression, negative mood, and to improve self-esteem and cognitive functioning associated with improvements in quality of life. And lastly, weight loss interventions resulted in weight reduction and weight gain prevention. For the systematic review question addressing early intervention, it has been found that early detection and rapid intervention may reduce the impact of serious mental illness and may even delay or prevent the transition to serious mental illness. 4 interventions demonstrated strong evidence. Cognitive remediation therapy that I mentioned previously addresses working memory, attention, direction following, and executive functioning, and this demonstrated improved cognition, self-esteem, and social and occupational functioning. Cognitive behavioral therapy, which is an active problem-oriented intervention targeted at changing maladaptive thinking with enhanced thinking strategies, demonstrated improved functioning and reduced risk of conversion to psychosis up to 24 months. This is of concern because conversion to psychosis leads to decreased occupational functioning. The third intervention of supportive employment, again with the individual support and placement model, yielded better competitive employment rates. And lastly, family psychoeducation reduced symptoms, improved social functioning, and improved family communication. For the 5th question, addressing self-stigma, which is defined as a process in which the individual living with mental illness adopts and internalizes the stigmatizing opinions of society, such as the idea that the person is dangerous or incompetent. Internalized stigma is believed to have a negative impact on self-esteem, social relationships, and functional outcomes, and often leads to self-fulfilling prophecies of failure. But interventions lack strong evidence currently. Psychoeducation demonstrated moderate evidence for improved hope, self-esteem, and quality of life. Interventions with limited or insufficient evidence included cognitive behavioral therapy, social skills training, narrative enhancement and cognitive therapy, group discussion, and vocational rehabilitation. The issue of stigma is a critical concern for adults living with serious mental illness, and yet research for effective intervention is only at the very preliminary stage. With further research into interventions addressing stigma, hopefully there will be support for effective intervention. Having reviewed the practice guidelines, descriptions of evidence for effective interventions, the OT practitioner in our ACT example returned to the compiled data of occupational challenges experienced by the ACT client. To obtain desired intervention outcomes, the OT practitioner determined which interventions demonstrate strong or moderate evidence to yield these outcomes for the ACT client. Applying the knowledge translation process, the OT practitioner implemented relevant interventions, utilizing the specific methods of these evidence-based interventions. Thus, the practitioner was able to develop an evidence-based practice intervention program to meet client occupational needs within the ACT setting. Listed on this slide are relevant interventions with strong evidence from the systematic reviews, which can address the occupational challenges experienced by the ACT client. As practitioners, we can have confidence that these interventions are designed to achieve the desired outcomes for the client. Returning to the title of this webinar, Applying Evidence for Best Practice in Mental Health Settings, I would like to highlight professional reasoning used in this program development process for evidence-based practice. In this example of designing OT add-on services in the ACT program, the OT practitioner reflected on the following questions. First, what are the steps of determining client challenges within a specific setting? How does the needs assessment enable OT practitioners to consider suitable interventions within the program development process? Second, how does the OT practitioner use reflection within the knowledge translation process for best practice? And third, what evidence-based interventions will obtain the desired outcome? In this ACT example, what interventions were identified to meet clients' needs for community living? As a result of asking these questions, the OT practitioner selected interventions for occupational engagement in the areas of ADLs, IADLs, social participation, and leisure to include occupation-based, psychoeducation, and skills training intervention. In the areas of work, to include interventions for supportive employment with the IPS model. And in health management, addressing health and wellness, to include interventions for physical health, relaxation, exercise, and weight loss. Within these interventions for occupation, the OT practitioner addressed underlying issues in the areas of performance patterns and performance skills. Creating practice stories of implementation of current evidence-based interventions is part of knowledge translation. I hope that you will join me in sharing examples of evidence-based practice. Please contact me if you're interested in sharing your practice examples. I would also invite you to carry this conversation onto the Mental Health Forum on Community. While I'm going to answer questions next, I'm sure there are many more thoughts and conversations that we can have. And using the Mental Health Forum is a great place to have these discussions. Okay, I'm going to look at questions that are coming in and hope that I can answer them in ways that are effective. Okay, so one of the questions is, if you work in a state in which OT is not considered a highly qualified mental health provider, is this model legally meeting the licensure laws? So I'm going to think for a moment about this question. What I'm hoping you're asking about is this clinical reasoning process or professional reasoning process that I described with program development is what we need to do to demonstrate and validate that we're effective mental health providers. There are many, many factors that we as a profession need to address to move the profession into recognition that we're qualified to provide mental health services. We need to look at the issues of awareness of our distinct value. We need to look at what are the reimbursement structures. We need to look at what are the licensing agreements for all the professions providing high quality mental health services. My suggestion is that as we look in each state, and there is a lot of variability state to state, that we and our mental health OT colleagues need to ask the question of where are the current barriers and how do we educate and advocate for the benefit of our services. But being able to present evidence that demonstrates effectiveness is a really critical part of moving us either within licensure or other state regulations to being considered qualified mental health professionals. And in some states, that's an official term, qualified mental health professional. In other states, what we really need to look at is how do we demonstrate our viability as providers. All right, the next question. Can you please expand on the difference within OTPF4 as related to the addition of health management? Because I had the privilege of serving on the Commission on Practice while OTPF4 was being developed, I had the opportunity to be part of the discussions of whether we should add a ninth occupation. Much of the interest in doing so came out of the importance of health literacy and the many professions in the healthcare arena that are recognizing health literacy is important. For OTPF4, we hope to craft language that addressed the performance of health management. What skills and abilities do we need to help our clients develop to be managers of their own health? So if you go to OTPF4 and look at the broad description and the specifics under the occupation of health management, I hope that you'll see that this is a useful addition. We know from many of our clients who live with serious mental illness that the discrepancies in health and lifespan discrepancies are critical issues. And so I hope that we can all join together in really expanding the use of this occupation within our clients. All right, the next question. Can you address any specific evidence-based practice related to parents with serious mental illness in the context of their role as parents of young children while they're living in their own homes? All right. So these practice guidelines address the adult population. I'm rereading your question to make sure I'm addressing it. So if the adult is the person living with serious mental illness, then absolutely we need to look at their role of parenting for their own children. The occupation of parenting did not get a systematic look or analysis within the interventions that were incorporated into the practice guidelines. As I said in the presentation, to determine content areas to look at, it was understood that there would be many, many factors and aspects of living with serious mental illness that could not be reached within these particular practice guidelines. I'm aware of some interventions, but certainly I, as well as you, may need to do our own research at looking at what evidence there is. I agree that parents living with serious mental illness certainly could benefit from some of our service in terms of helping them with their parenting roles. But unfortunately, I don't have a lot more detail. The next question. I noticed that the ACT program described in my example was an urban area ACT team. Is this program model limited to urban areas? Or for example, is there a different model for urban areas? To prepare for this webinar, I decided to pick one practice model. I think that many of the ACT teams are very effectively working within urban areas, but the intensity of services and the focus of an ACT team may have challenges in rural areas. But this does not mean that I know that the ACT model is less effective or ineffective. I simply don't have that information, but again, I think that that certainly would be something for us to look at, because the model of wraparound intense services for the client is needed regardless of whether the clients are living in urban or rural areas. Okay, the next question. Could I summarize the difference between cognitive remediation therapy and cognitive behavioral therapy? And which of these, if any, do you think are suitable to the OT approach? Okay, this is a really good question. Cognitive remediation therapy is a manualized program. The vast majority of it is done using computerized programs in which clients move through exercises designed to improve their cognitive skills. So that of working memory, following directions, attention to detail, all of the things that we think of are basic cognitive features. Some of the cognitive remediation programs I've experienced or been involved with do just these computerized exercises, but more of them have at least one session a week. They may have 2 computer sessions and then 1 session for application, but they're talking about then how do the clients take their increased memory or their increased following directions into the tasks they need to do in their daily life. So there's that application piece. The cognitive behavioral therapy is really more a way of having clients stop and look at thinking strategies that just aren't working for them, that are just not effective. And the prime sort of methodology is to have the client stop recognizing what's not effective in their own behaviors, and then learn and practice more effective thinking strategies, which then they implement in their daily life. So the final part of this question was, are either or both of these suitable? My thinking is, and my recommendation is, that both of these overall interventions have developed outside of occupational therapy, but they're absolutely appropriate for occupational therapy if we're utilizing them within assisting clients within their occupational performance. You know, I certainly as an OT don't want to just be administering cognitive remediation therapy, but I can utilize some of those strategies if I'm helping clients move towards greater occupational performance. And so I'd encourage us as OT professionals to think about both. All right. The next question. Interesting to note that CBT appears to be effective for addressing employment and early detection and intervention, and yet it wasn't identified as addressing ADLs, IADLs, and social participation, leisure, rest, and sleep. Are there thoughts on why? All right. So when the systematic review teams went out, collected all of the intervention research studies that applied in each of these questions in the area of the ADLs, et cetera question, the CBT interventions did not demonstrate effectiveness for the ADL, et cetera question. It just didn't come up as demonstrating effectiveness. That doesn't mean that CBT is inappropriate, but we don't have the evidence for effective intervention. So that leads us to two things. One, we as OTs could go out and conduct the research about using CBT within these occupational areas, or we can investigate more fully, are there other bits of research that give us evidence for effectiveness or lack of effectiveness. Certainly when the early intervention for psychosis systematic review team went out and looked at the interventions being used and researched, their CBT demonstrated effectiveness in early intervention. The next question, could you give some specifics of examples of mental health interventions to be taught in OTA curriculum? All of the interventions I've talked about or included within this webinar, I think are very viable for our OTA colleagues. The distinction within our profession in the OT-OTA team puts responsibility on the OT practitioner for that initial evaluation and assessment and that initial intervention planning. But doing that with a colleague from the OTA practitioner is really important. So in my thinking, the OT and OTA would partner and look at what interventions can be easily carried out. If you go to the resource of the practice guidelines, or you go to the evidence connection article that I and Dr. Susan Noyes wrote for AJAP, all of those cases have examples of a partnership of OT and OTA practitioners. So I think you'll get some good examples, but I don't think it's a matter of which interventions should be taught to our OTA practitioners, but how do the OT and OTA practitioners team to provide the intervention services for the client. The next question is, during my time in acute care, what assessments did you find most useful in attempting to develop a plan of care in acute care settings? Assessments are another huge topic. My answer really is that I would suggest that you do the same needs assessment that I outlined in this webinar and determine what are the typical characteristics and occupational needs of the clients coming into the acute care setting you're working in. With that information, you can determine what are the occupational challenges, and then you can select assessments that are relevant to giving the OT practitioner data about the client. Let's talk about other webinars and other continuing education programs that we can develop about assessments, because certainly that's a huge topic. The next question. Given mixed results of CBT, should we continue to teach CBT in entry-level academic programs? I think it's a tool. I don't know that we need to enable our students to be experts in this particular intervention strategy. What we should do in entry-level academic programs is teach an awareness and a good understanding of how CBT is an effective intervention embedded within our services to enhance occupational performance. I think this question comes up across many different practice areas. Do we need to develop full expertise in our students, or do we need to help them understand the basic foundations and how to implement them? And then CBT is an area of further continuing education that some practitioners need to or may choose to follow. So the next question is, are there any of these evidence-based studies that are useful to consider within the inpatient setting? I very purposely chose the ACT community-based program to develop this webinar, but none of these systematic reviews that described existing evidence are limited to community-based settings. The responsibility of us as OT practitioners is to review the existing evidence, and we've got the tools of the practice guidelines that have already compiled it for you to see what matches the needs of clients in the inpatient setting. If we're looking at acute care, we're with our clients for very short periods of time, and hopefully we're making good recommendations for services to follow them out into the community. But if we're working with clients in long-term inpatient settings, there may be interventions that are very appropriate for us to use. And so I think you really, again, need to go back to what are the services you're providing, what are the missions, what are you trying to accomplish through the OT services that you're providing. The next question, are you aware of OT supportive programs in women's and children's shelter environments? That's a really important question. It just doesn't happen to be within the areas in which I feel comfortably knowledgeable. But please take this question to the Mental Health Forum on CommunOT. There are a lot of members of AOTA who have wonderful information and expertise to share. So please take that conversation there. The next question is, can you make any suggestions for someone who wants to consider transitioning into mental health services? Oh, please do. We need as many of us as we can. My suggestions really are to, find some critical resources and review them. and really to look to see where you can find practitioners who can serve as your role models and help mentor you. I'm a huge fan of mentoring, and so I think talking with people who are currently in OT practitioners, currently in mental health services, can be wonderful folks to guide and mentor you. So I look around in your community or the community that you hope to be in, the physical community, and see who is already there. Look to your state OT associations and find people who can mentor you. And really think about, is this a practice area you'd like to, move into? The next question, I would like to see AOTA take a more active role in training OT practitioners and IPS. When can this become a reality? Oh, you're speaking to my heart. I am a huge fan of supportive employment, and OT professionals have just not been included in the package. And we need to find systematic ways to have conversations with the many practitioners who are involved in supportive employment and specifically individual placement and support. It takes many of us to begin to do the education that's needed. Okay, we're probably getting very near the end of our time, and I want to thank you for listening, and it's been a pleasure to be with you. Thank you.